Assalamu alaikum everybody. I welcome you all to the second lecture of the series organized by with Dr. Professor Anis Bhatti sir. Let's start with the words of Holy Quran. Bismillah ar-Rahman ar-Rahim. Inna a'tainaka al-Kawthar fasalli li rabbika wanhar inna sha'niyaka huwal abtar. First of all, I welcome all of you and especially our Professor Anis Bhatti, and we all pray for his full and immediate fast recovery, and we are thankful that he is with us, and with all these health issues he has taken out time for the students and for this teaching, which cannot be which should be appreciated by all of us. So Chirag Sahab has also, I think, joined us. We welcome Chirag Sahab with us as an expert of this series. Now I ask Professor Anis Bhatti to start with his presentation, sir. Thank you, sir.
Bismillahirrahmanirrahim. My today's assignment is on the DDH principles and protocols in less than 1 year age group. This is a second lecture in the series of DDH webinar by Dr. Ziauddin University, Karachi. These are experts with me, the faculty of Ziauddin University Hospital, you know very well, Professor Ghulam Mahbub, my mentor, and my grand mentor, Professor Chirag Muhammad Khan, a legend, living legend with us. And this is my agenda of the objective of the treatment in this age group, principles and protocols. Then I will concentrate more on hip abduction bracing, how, why, and when has to be applied, and in case of failures, indications for the further spica cast management with without arthrogram. And the last, I will give you briefing on the bracing application of the Pavlik Harness, which is most commonly used. It is said if DDH is undetected, it will lead to some unacceptable disability of limb without pain lifelong if it is not treated in time. But when we mishandle it with shortcuts and improper treatment, it leads to more devastating complications like avascular necrosis and sepsis if you do open reduction, and that are not treatable and that will remain with lifelong with the patient. So mishandling is very, very dangerous in DDH and other surgical aspects. And this is few examples of the mishandling and shortcuts in the surgery. If you do the shortcuts and mishandle, definitely you will go in the disasters, and disaster common in the DDH is AVN, which remains lifelong disability. Now the principles of management of DDH in younger age group less than 1 year. We have commonly seen this picture. In the solar eclipse, you always see the children are buried in the mud at the sea and the river sides for management of the deformities. One of the aspects in this particular in South Asia countries, the people think the deformities congenital which are born with the children are due to the moon eclipse. If you treat them with the sun eclipse, they will get treated, but this is all rubbish. Protocol number 1, or principle number 1, is the age versus age results of the treatment. It is very commonly studied and well elaborated thing that younger the age at the treatment, better the result as skeletal maturity. Many literature is available, but the classical literature of the Ketral and Zadeh and Nijad is available in 2000 JBJS, which shows the AVN and ridge dislocation as per age groups. If you treat these patients in less than 2 years age group, the success rate are excellent and good results are 95%, which gradually decreases as the age increases. And when you treat this below 5 years age group, from 2 years to 4 years or 5 years, the results are 80% good and 20% are the fair or the poor results. But the age increases and anteroradiate cartilage starts stiffness and decalcified by the 8 years, the results become much less good and satisfactory. But when you treat these children after calcification of the triradiate cartilage by the 8 years, results are 50%. So there is progressive deterioration of the results and the more number of complications as the age increases. So principle is the treatment is once it is detected in most earliest age, before walking or crawling must be treated fully and to get the skeletal maturity best results. And the goals of the treatment and the DDH are the anatomical, concentric, stable hip. And these three factors are provided to provide an optimal condition for mutual growth stimulating effect of femoral head and the acetabulum for growth. When the hip is concentric and anatomical, the head of the femur produce a growth stimulating a pressure effect on the acetabulum, and same is the weight of the body on through the acetabulum to the head, and it produces a congruent hip. That is called mutual growth stimulating effect of the femoral head and acetabulum. And second principle is the treatment tailored according to the age of the child, according to the pathology. And this is the most important wordings in the Campbell. It is written, the treatment should be tailored according to the age, and it should not be rigid as per age, but also with specific problem or pathology of the patient. If age is younger, the treatment is good, but when the pathology is like arthrogrypotic children or children with the teratogenic hips, they must be treated completely. Open reduction, if needed, must be done before 1 year of the age. Otherwise, the Campbell and other literature says that open reduction should be limited to the age after 1 year of the age. So 50% of babies when diagnosed at birth become normal within few months of the age without treatment. These are those hips which are very less unstable, and there are fine clicks you feel, but they become normal within few months of it. And most of the children which have the frank Ortolani and Barlow stress positive, they respond very well in 2 to 3 months of the treatment and the follow-up treatment. And neonates respond very well with the abduction splints instead of the plaster cast or any other appliance you applied. So hip abduction brace gives the best treatment result within 8 months or 3 months of the treatment, and 50% of the children become normal which are unstable at the time of birth. Therefore, they developed a protocol of the screening protocols, and with the screening protocol, they got diagnosis of the DDH. So now we are going according to the age, treatment tailored according to the age in less than 6 months of the age group. The protocol should be closed reduction, and it should be gentle closed reduction, but no pressure on the femoral vessels and the femoral head. And this pressure is particularly because of the position of the limb. Excessive abduction or excessive flexion may produce a problem in the femoral nerve, femoral sciatic nerve, and the blood vessels, particularly the anterior branch of the circumflex artery, the odd position reduction. So maintenance in abduction splint in monitoring is again an important and goal in the 6-month age group, again anatomical, concentric, stable hip in abduction splint. So here are the protocols of hip abduction splints. We commonly use two types of splint. Whichever is very commonly used is called dynamic splint, which is the Pavlik Harness, which is very easily available in our country as well. Then there are fixed splints, which we call the Boston brace or the Pavlik Boston brace, Van Rosen splint of the aluminium, which is fixed splint. Here the shoulder straps with the aluminium and the hip straps there and the chest belt. The child become very fixed in the abduction around 70 degree, and the similar is the Boston, which is soft brace, but nearly same as the Van Rosen brace, and the Craig splint. This splint is commonly we use in the post-operative periods, but it is also has been used. The world is commonly using the Boston brace, Pavlik Harness, and the Craig splint nowadays, and with the best result, but depending on the age group. The dynamic splint, that is called the Pavlik Harness, is mostly used in younger age groups, while the static splints are used mostly over the 6 months and in conditions where the hip is yet remain unstable with the dynamic splints. I will also show you the example of one of this in the next series. So details of the Pavlik Harness is in standard therapy for the infant younger than 6 months age, and the principle is to hold the hip in flexion of around 100 degree to maximum 110 degree, abduction from 50 to 70 degree, not over the 70 degrees, and to allow this gentle close reduction and stability. There are two thoughts. One is that the Pavlik harness should be applied after mother are trained to reduce definitely it should be applied in reducible hip, not in unreducible hip. And other thought says when you apply the hip Pavlik harness in abduction and flexion, the gradual pressure of the gravity of the limb will reduce the hip joint in the acetabulum with this position. So these both thoughts are valid, that it reduces with the continued Pavlik harness, and other is the mother must be trained for checking the hip is already reduced. Standard position in Pavlik harness already described by the anterior straps. Anterior straps will produce a 90 to 100 and 110 degree flexion, and the posterior straps here is the posterior straps which puts the hips in abduction, and this abduction should be around 50 to 70 degree, not more than 70 degree, to prevent the sciatic-nerve and femoral stretch and vascular stretch. This position of the Pavlik harness minimizes the risk associated with over abduction, hyperflexion, which are associated with the osteonecrosis and femoral nerve palsy. The harness is initially worn by 24 hours, and you must mind it there, this harness is flexible. It is made of the cloth and the cloth straps, and there is a dynamism in this abduction splint, which I will show you in the next slide, how the dynamism works, and keep reduce the hip and keep reduce the mobility inside the hip joint as compared to the. For the Pavlik harness, mothers has to be trained for the autonomic crick and the Barlow's test, and particularly the Killis test, that the palpation of greater trochanter and distance from the greater trochanter to the iliac crest should be at least around 5 centimeters. And the other thought, as I already said, the position of the flexion and abduction in the Pavlik harness itself reduced by the gravity. So when you maintain this reduction, it should be maintained for stability, and stability is usually achieved in 3 months, around 3 months, 8 weeks, 10 weeks to 12 weeks, and then it should continue for remodeling of acetabulum for 2 months with weaning. Weaning should be for 2 hours. That must be doubled every week until a normal hip is achieved, that is around the 9 months, and it should be done, monitoring should be done every week, particularly for ultrasound first 2 weeks or 4 weeks, and then every 4 weeks till the good stability is achieved. There are risks of failures in the Pavlik harness, particularly when the Pavlik harness is applied delayed after 7 weeks. Usually hips become stiff in the 7 weeks, and reduction is less possible, particularly in around the 8 weeks. Therefore, it should be applied immediately when it is diagnosed at the time of birth or at the first immunization within 1 month of the time. And other is the negative allele, stiff hips, as in the arthrogryposis. You find an stiff hip, you should not initiate this treatment with the Pavlik harness. It will produce a problem. And sometimes in the bilateral hips, I have them a few cases in which the bilateral hips were applied the Pavlik harness, one got reduced, other got unreduced, and we have continued then on the close reduction. So these are the failure risks, but there is a warning that the treatment of a hip in dislocated hip position for more than 3 weeks leads to flattening of the posterior wall, which makes the posterior wall, which makes the subsequent close reduction difficult, and the acron type of the femoral head. It means it should be perfectly reduced, and then it should remain reduced. Then you should continue the Pavlik harness, and it can be seen by the daily monitoring by the parents and the physician's visits at the fortnight visits. And Pavlik harness one fails, then there is an indication of the other treatment, that may be a close reduction or surgical reductions. When you send a patient to the vendor, they apply the vendors in this particular position. You must check when you ask them to bring this Pavlik harness, you train them to apply the Pavlik harness, and feet is free. When feet is free, it is not working. It should be at least feet is engaged. Once it is engaged and the chest belt and the nipples, that will work very well. And other is the monitoring with the ultrasonography. So proper application training the parents, weekly ultrasound for work weeks, and then follow up fortnightly. In breast checkup, is you check in the breast is there. It should not be completely adducted. Hips should not be completely adducted, and search zone is observed, and proper application of the foot straps and the chest belt position. Anterior position should be axillary, vertical position which should be at 90 or 110 degree, abduction not more than 70 degrees, and the ultrasonic reduction. It must be checked, monitoring at least 4 weekly. So these are the few examples of the Pavlik harness application. This is the right sided DDH, which is reported to JPMC at the 4 months of the age. This Pavlik harness was given in 2010, and this is the dynamism. This dynamism shows the hip is in the flexion, normally, but when the child kicks, the foot steps keeps more abduction and more flexion, and it pressurizes the hip joint towards the acetabulum, and it causes the good remodeling of the acetabulum and stability. That's why it is called a dynamic splint. Here is the same example. Baby is very comfortable in the coach. Nappy can be changed very easily. I will demonstrate in the last portion. And then the follow-ups in the breast by the X-rays around after 4 months of the age or 6 months of the age, and the ultrasonography. And this is the in-breast photograph of the X-ray at the 5 months age. And this shows the results of this Pavlik harness at 6 years age. Hip is well contained, and both hips are comparative and normal. Absolutely. This was around 2016 or 17 when this photograph was taken. And this is another example in which there was a bilateral hip dislocations type 2, and this child was given a Pavlik harness. And for the Pavlik harness, he could not maintain the reduction on the right side, particularly like this, and at the 5 months follow-up. So on the left side, it was absolutely normal hip he developed. Then I gave a cast for the 2 months period, and after cast, I gave this child a Boston brace for next 2 months. So total treatment was around 9 months. At the 14-month age group, this was his age, and this is at the follow-up at the 20 months. And this is the Boston brace which he could purchase from the USA, and this was the reduction on one side and other side. And at the 2 years age recently in November, first week of November, he had a 2 years follow-up, and this is his photographs in the Pavlik harness. So it means bilateral hips, sometimes one hip reduced and other hip may not be reduced. So you may need a close reduction, and close reduction followed by Boston brace, or the simple Craig splint we can use, and then the follow-up of the 2 years would show the excellent results in this age group. This is a bomb like this. The Pavlik harness is inside, and the gentleman has given the bracing over there. That is called swaddling. Swaddling in the unstable hips is dangerous, in particularly in the high risk section. This should not be. This is very common in our country, and even in my family they are using. This is one child. I will also show the example which I gave the bracing and with the CDK, but she continued with a towel. बच्चा जो है छरकता है, बच्चा परेशान होता है, so it caused a failure. Then I have to apply a close reduction cast, and ultimately he got well. So I consider swaddling as a bomb of these has been applied to these children. Swaddling is not good. This is a fixed splint. The Boston brace, the Pavlik harness, one Rosen splint, and the Craig splint. These are mostly applied when there is still instability is continued in the Pavlik harness, or when the age children is more than 6 months and clunk is feel instead of click. So these are Pavlik harness failure to prevent the adductor reduction of the T to 4 minutes. If the child is greater than 6 months, then rigid abduction orthosis is used, and this is the hip aluminum strip hip side, and there is no abduction, but this hip continued, and this type pressure on the popliteal fossa. And then there is chest belt and the aluminum strip of the shoulder. That's called the Van Rosen splint. And the common example with this fixed splints are the number of necrosis as compared to the Pavlik harness. So prolonged transition period for many prolonged use of rigid orthosis person dislocation leads to development of the saddle or acron shape. I already told you, when unreduced hip are continued with the Pavlik harness or the fixed splint, they usually produce a central avascular necrosis clamp 3, and ultimately they develop a saddle type of the femoral head which remains lifelong person. Most commonly brace use are the Craig splint, Van Rosen splint, and Pavlik harness. And Pavlik harness is used more than less than 6 months age group, and the fixed splint are used over the. Pavlik harness is very popular and very well studied, and it has become an standard treatment for majority of children younger than 6 months, as it is most thoroughly examined, found to be safe, highly effective, and good success rate in over 80%. And this sometimes harness produce a disease which we usually call avascular necrosis or stiff hip joint and acetabular dysplasia, which is usually called as a Pavlik harness disease. And this is mostly, it is seen with all these, but less with the Pavlik harness compared to the Craig splint, splint. So here is one of the example of the persistent use of the Pavlik harness. Even after the good reduction, it was continued for 12 months. And this 12 months continued period resulted in AVN, which is type 3 Kalamachi. This may lead to this 12 months follow-up, and which may lead to saddle type of the treatment. Age group after 6 months, protocol for the treatment over the age of 6 months to the 12 months of period. It is said golden period is 6 to 18 months. It must be reduced within 18 months duration of the age. Close reduction or open reduction with a spica cast is the commonly used in this age groups over the 6 months age group. But indication are the bracing failures to provide adequate reduction. Infants older than 6 to 9 month age with not easily reducible hips, and it means a rigid hips. And Campbell said, as already said, treatment tailored according to age and pathology. When there is a rigid hip, unreducible hip, and there is bracing failure, you may opt for the close reduction. When we were in the as like you trainees, we used to apply a preliminary traction. This is a picture of 90s. In Ward 14, we applied the gallows splint for early traction. And once we achieve the reduction, we do the close reduction with adductor tenotomy and also sometimes arthrography. So treatment protocol preliminary reduction used to be the preliminary traction, then close reduction, arthrography, MRI, close reduction under general anesthesia with or without arthrography. When you do the arthrography with close reduction is better. But in the US and world, we have seen in last December, you do the MRI in the MRA in the operation theater to know the vascularity after close reduction. And the main aim is the good quality of initial reduction and observe the safe position criteria, particularly when you are applying the plaster. Currently preferred method is the close reduction under general anesthesia, no preliminary traction, and arthrography at the table or MRI is already come to confirm the reduction. And sometimes they also see the vascularity of hip after close reduction. So acceptable safe zone principles of the Ramsey, this position of between abduction between 20 to 40 degrees is good, stable. When reduction position is less than 20 degrees, it will produce dislocation. When it is more than 45 or 50 degrees abduction, it may lead to the avascular necrosis. And the flexion over 100 degree is the safe position criteria of the Ramsey. So this is Ramsey criteria. You can go through detail in your books. And the cast is applied again in the same position. That is Ezra flexion and abduction. But it also depends in which nowadays you have availability of the C arm. So you can see which is the good position of stability, either frog-leg position or the Lawrence position of internal rotation. This was the child I will show you the example. It was stable in flexion, in the extension and the internal rotation, while this child was stable in the flexion or the frog leg position. So these are the few examples of the close reduction. This child came for the second opinion whether this hip has been reduced with the plaster cast or not. And second opinion, I found by drawing a Van Rosen lines that hip is not in the position. So X-ray usually sometimes become confusion. So you do the CT scan. When I done the CT scan, it shows a little bit out. It's not crossing through the acetabulum. So I reduced it, this hip joint, and the position was the internal rotation, 15 degree of flexion and extension. And this is the 12 months follow-up of the same child and good progressive hip joint. So another example of bilateral DDH, very unstable hips. Since beginning, she was getting the treatment for the Pavlik Harness treatment, but when she came at in the 6 months age group, ultrasound, every time ultrasound shows a borderline picture, but the impression wrote there was no DDH. But this is a borderline. 50 degree angle should not be more than 50 degree, and this angle should be more than less than 60 degree, more than 60 degree beta angle, and there is a disparity. So I consider this hip as a borderline hip. So there at 6 months age, I found this that it is unstable. Click was also positive, and the Van Rosen X-rays also shows some hips is out of the hip joint. I advised him close reduction, but they went to another consultant who continued the treatment with the continued the Pavlik Harness. Both hips are, this is type 2 and this is type 3, and my impression was the tone is 2 and 3, and ultrasound was done, and I advised them for the close reduction plaster cast, but they continued with the Pavlik Harness. But at the 9 months age, again there was a subluxation clinically, and ultrasound shows the same picture but no interposition of the soft tissues. Again, I advised them the close reduction, which was done in September. And in September, this close reduction was done with the adductor tenotomy and arthrogram. And this arthrogram shows bilateral good reductions. And when I achieved a good close reduction, I applied a cast which shows absolute normal anatomical concentric hips, but in the frog-leg position. So then there is a group of children which comes to you after 9 months, below 12 months of age, year age. In this age groups, usually close reduction is sufficient, and Campbell and the multiple literature, I will show you how they write the close reduction particularly. But some people, literature shows there is open reductions when there is a failure of the close reduction, and timing of surgery and the surgery and approach is controversial in this less than 1 year age group. And early reduction expected these are the literature. Early reduction can be expected to lead a normal development hip. Thus, if required, open reduction be done as early as possible. In 2007, very few reports on OR is available in age groups between 8 months to 12 months after, particularly with the Ludloff and the Westin approach. But these are the recent literature of again of 96 and 97. But the Cattrall and Zade in 2002, a classical patient is called, is currently, he wrote that currently there is a voyage of open reduction carried out by medial approach in first few months of life. Deliberate delay open reduction was until about 1 year. The result has been unacceptable, severe 1 and 2 in 95% of procedure with when children are carried out up to the 2 years of age group. It could therefore be argued that the open reduction is required to operation is best delayed until 1 year of age. So they recommend, and nowadays also it is recommended that you must at least, unless it is a rigid hip, unless it is a heterogenic hip, you must wait for 1 year and try for the close reduction and maintain in the close reduction. But literature is there which shows scopic reductions in less than 1 year age of group, and that is from the 6 months to the 12 months of the age group. And there are multiple literature available from 2005 to 2000 nowadays, and very classical literature publication of Eberhardt from Germany was there, which shows a good results, 69%. Actually this shows the complication of the age groups when open reduction is in. AVN with open reduction, medial approach up to 69% due to the circumflex injury. Arthroscopic reduction has less chance of AVN as capsular release is more superior lateral and chance of damage to median circumflex artery is minimum. And this again shows by the Zade, the effect of AVN may not appear in earlier but in the older age group. Therefore, they recommend the treatment should open reduction should be after 1 year of the age group. This is few slides for arthroscopic reduction of the open reduction of the hip in less than 1 year age group. Two portals are used. One is subadductus portal, 1 centimeter anterior to the ischial spine. This is the instrument for the camera, and another probe is used from the anterolateral. It is called the anterolateral portal of the anterior superior leg spine to 1.5 centimeter below, lateral 1 centimeter lateral to the femoral artery. And cannulated arthroscope was inserted, and then the dissections are. This is the ligamentum teres, very well visualized, which occupies whole of the acetabulum. This is the superior labrum. This is the pulvinar. This is the pulvinar, and this is the attachment. This is the attachment of the triradiate transverse ligament, acetabular ligament, from where the ligamentum teres arises. So they dissected, they cut the ligamentum transverse ligament, remove the ligamentum teres, remove the Pavlik, the pulvinar, and after pulvinar they find excellent, close, good reduction of the hip joint. This is classic artery. There is multiple literatures which shows the how much the good results with arthroscopy. They convince for the arthroscopic reduction, but the experts are doing this with the good results. But even then, there are chances of the AVN compared to the open reduction after the 1 year of it. In Peshawar, Sikandar and the Salik are doing the medial Western approach in younger than 1 year age group, but they have not yet published their follow-up results. And this shows the results of the acetabular index development after the arthroscopic reduction. Perioperative acetabular index was 35 degrees, which reduced to 23 degrees, and from 70 to the 17 degrees. So again, a conclusion: the timing of surgery and surgical approaches are controversial. Early reduction can be expected to lead to normal development of hip. If required, open reduction to be performed as early as possible, but particularly with the arthroscope. And this is again another study available. So here are a few examples. I will give you some examples. This is one of the child which has DDH with the many children, DDH with the TEV. I do the bracing when after close reduction of the Ponseti treatment for clubfoot. During the percutaneous tenotomy, I continued the bracing from very beginning, and again in the splint. A splint already keeps the hip in abduction. When you apply the brace, they give you good reduction of the stability, and I found very good results of the DDH with TEV with Pavlik harness continued over the cast and the bracings. This is one of the another example, very rigid arthrogrypotic child with having the bilateral congenital knee dislocation type 3, which was initially managed by the conservative management, but I could not achieve more than 50 degree flexion, so I opted for the VY-plasty at the 6 months of age group. But then he also had a type 3 tonus hip dislocations, which I continued with the bracing, but the mother could not continue the bracing particularly properly, so I advised them to have a Fritzka pillow. She made this Fritzka pillow, which she continued till the good achievement of the result. I will show you. The hip is well contained. This is the Fritzka pillow prepared by my mother on my guidelines, and with the cast after open reduction of the seat decay, we continued the Fritzka with the Fritzka pillow, and this gives excellent hips joints and the good stability of the hip joints and the knee. There is another example of the DDH with the clubfoot, and the bracing continued with the clubfoot treatment, and the abduction, foot abduction splint is there, and the hip abduction splint is there. He developed a well-contained hip joint in the long-term deployment. This lecture is dedicated to my mentor, Professor Yunus Haider Sumro. He is also the mentors of many, and the genius. Allah iski maghfirat farmaye. Take home message: always balance the hip joints. If you not the balance the hip joints, you cannot balance them. And keep your energy safe by quarterly visiting out of your all these headaches. Now question answer session.
So a question by Dr. Mazhar Baloch is: what is the appropriate duration for maintaining the hip spica after close and open reduction? Dr. Anis?
Spica is usually applied when the close reduction with the Pavlik harness is failed. Hip spica usually should be continued minimum 2 months, period, and it is I usually give you about the 2 months to 2.5 months, and then remove this spica cast and give the Craig splint. Craig splint is very easily available in our city, and some people bought the Boston brace for next 2 months. So total duration must be at least 4 to 5 months duration. So total period from beginning becomes to the from the 1 month age to it becomes around the 9 months of the age group. So it is the 4 months total, 2 months in the fixed the spica cast and 2 months in the removable Craig splint and the Boston brace or one rosen splint is sufficient. Check first with the one rosen view, and after removal of the cast with one rosen view, is it stable? If it is stable, then you apply the Craig splint, and you can also do the Craig splint X-ray in the Craig splint, which shows usually is a one rosen view.
Okay. Dr. Satish Badani wants to ask regarding adductor tenotomy, should it be closed or percutaneous? And which adductor muscles are divided and which are preserved?
Adductor tenotomy classically is the tendon of the adductor's longus tendon tenotomy. It is usually percutaneous as we do the TAL in the percutaneous TAL in the pauncity. Same is the reduce the hip joint. You will feel there is a prominence of the adductor tendon. Once adductor tendon you feel, you pinch on the both sides of the adductor tendon, and with the 15 or the 11 knife blade, you can cut the tendon only. When you cut the tendon, muscle itself gets stressed.
Okay.
This is the main, again, a factor for the recurrence in the callus reduction. If you not cut, this may produce a recurrence.
Good. Okay, sir. Thank you. And Dr. Shazia want to ask the role of splints in arthrogrypotic patients.
As already I said, the Campbell has written treatment tailored as per the age and the specific pathology. When there is a arthrogryposis, their muscles are very rigid. Even on the open reduction, you have seen the stiff muscle, fibrotic muscles. So callus reduction usually is better with the fixed split. It is better the Pavlik Harness. If it is not stable with the fixed splint or the Craig splint or Boston brace or the one rosen splint, you can apply the callus reduction. When we maintain in the callus reduction, if it is stable, usually sometime, most of the time I would say, it may get out if it is not kept more than 5 months duration period, the spica cast, and it may re-dislocate. And after age of 9 months to 10 months, you can do the open reductions. And in this particular group, you can also do the pelvic start me earlier than in 18 months age group.
Okay, great, sir. Dr. Kiran Jaffrey wants to ask how many of the patients with Pavlik Harness treated patients needs adductor tenotomy in your cases?
Tenotomy is not needed in Pavlik Harness. It is only in the callus reduction when a patient is under general anesthesia. How can you do tenotomy in GA when you are applying a Pavlik Harness? Reduction and open reduction, not part of the Pavlik Harness.
Okay, sir. They want to ask decision making regarding type of splints. You have already asked. He wants to ask either they are age dependent or surgeon choice. The Boston, the Craig, and the Von Rosen.
Both. It is the age, less than 6 months of age. World literature whole writes for the Pavlik Harness. They also tried the Craig splint, not the Von Rosen, and only classical literature double AO is available. Only 3 they have given the references which compared the results of the Pavlik Harness and the Craig splint and the Von Rosen. Craig and Von Rosen and the Boston is similar. There is no gross difference. In the Von Rosen there is a chest straps, but here it is a pelvic belt available in the Boston brace. It is not the choice of the surgeon, it is also the availability. Boston brace is not available in Pakistan. We have to purchase from outside. Craig splint is easily available, and the Von Rosen is also available. Over 6 months of the age group, when there is a little bit rigid hip and a stiff hip, you apply the Von Rosen splint or the Boston brace and the Craig splint. Craig splint I usually recommend in the post-operative duration because it is a little bit stiffer than the Von Rosen. There is a little bit problems in the change of the nappies in the Craig splint as compared to the Von Rosen. But here Von Rosen is easily available, you can apply the fix. So it is not the choice, but the principle. Principle is less than a 6 month age group, flexibility of the reducibility of the hip joint, and the stability after reduction is, as I already showed you, Pavlik harness. One side they reduced, other side did not reduce. Another Pavlik harness which was continued for 6 months, continued period, but it could not give the good stability. So there we have to do the close reductions in these cases. And this close reduction with arthrograph, this child is doing very well because it is more unstable. And I found his acetabulum coverage was less as compared to the other hips. The slope of the acetabulum is more as compared to the other DDH cases. Therefore, it was and because of but there was no interposition of the soft tissues as I seen in the arthrogram.
Dr. Nida wants to ask about how fast can we switch over from Pavlik harness to cast? How much should we wait?
At least 3 to 4 months you must continue if it is reducible, if it is continued to be reduced.